at ADB. In just a second. We have a distinguished group of panelists today and welcome your active participation in the session's question and answer session at the end. But let me first just begin by opening with a few quick observations. First, there is no healthcare without workforce. The issues of workforce development, the skilling, the reskilling, and upskilling of people across jobs and skill areas is one of the most important issues for the healthcare sector today. It is very timely to include this topic in ADB's 9th Skills Forum. Not only does it have a strong focus on lifelong learning and digital skills, but 2021 is also the WHO International Year of Health and Care Workers. The world is facing a global shortage of healthcare workers. The shortages are across a wide variety of occupations and skill areas, and the deficit will affect low and middle income countries the most. The numbers are hard to estimate, but may be as high as 18 million. Many governments across Asia and the Pacific are not yet planning adequate investment to meet the skills gap. Critical issues like acquisition of digital skills underlie innovations and expansion of services like digital health. So investing in the health workforce can boost economic growth and qualification and skill levels, especially for women, as well as of course, improve health outcomes of the nation. So our three panelists today will walk us through some of the issues and share their ideas on how to improve skilling of the healthcare workforce. There'll be time for your questions at the end, after the short presentations, in a question and answer session. But I encourage you to list your questions in the chat box as we go along, if you would like to. So now let's get started and let me introduce the first panelist. We're very happy to welcome Professor James Buchan. Professor Buchan has specialized in healthcare workforce policy analysis throughout his career. His background includes working at national level in the National Health Service in Scotland, his home country, just a second, and as a specialist advisor to the Health Workforce Australia, which is a federal government agency. He's also worked for WHO in Geneva and Copenhagen, and he's currently working as an advisor in Europe, Asia, and the Pacific for governments and international agencies such as ICN, WHO, and World Bank. He is editor-in-chief of Human Resources for Health, the peer-reviewed journal affiliated with WHO. So James will provide a succinct overview of the urgent global need for more healthcare workforce. And over to you, James.
Thanks very much, Wendy. Good morning, good afternoon, good evening, everyone. It's my pleasure to be able to do the initial scene setting for this very important topic. I have only 7 or 8 minutes, and I'm going to, in that time, focus more on issues than on data, because I think it's important that we have some sense of the backdrop in terms of the driving issues. I only have 4 slides, but I will move through at pace. Hopefully. So, to start with, what are some of the critical healthcare workforce challenges that are facing all countries across the Asia Pacific, and in fact, virtually or probably all countries in the world? Several issues which are on the agenda at national level and regional level and local level. The most important and driving feature is the one that Wendy has already mentioned, which is shortages. Those are numerical and skill shortages across the globe. And that is a gap between supply and demand, which is becoming more obvious because of demographic change, population growth, and aging, and obviously most recently by the impact of the COVID pandemic, which I'll come back to in my next slide. Second issue, distribution. Even the workers that we do have are often not well allocated to provide healthcare in underserved regions, underserved communities, and notably in Asia Pacific across many rural and remote geographies. A third point that we need to consider is, what is workforce? What do we mean by the term, and which cadres, which occupations are involved in the process of policy making and being considered as part of planning and education. The mix of the workforce is going to be critical as we move forward. It's not just about looking at each occupation on its own. And in particular, I think we need to give full consideration to integration of well-trained community health workers in the overall workforce. We also need to look at planning, and the starting point there is, what is the purpose of planning? It's not to generate data, it's to improve the alignment across education, regulation, and employment. The ultimate goal is a workforce that's fit for purpose for delivering UHC. And we must never forget that underlying it all, health is labor intensive, healthcare is labor intensive. So much of the costs of delivering healthcare are tied up in the workforce. And therefore, there is a critical need to be effective in terms of allocation of funding to education. That first slide essentially described a world which existed pre-COVID, exists now during COVID, and will exist with us if and when we get beyond the pandemic. We also need to recognize that the pandemic itself has placed huge stresses on health systems and therefore on health workforce. And if you look across the globe, you can see that all countries have been looking at trying to support a surge in terms of the number of workers they have and the skills that those workers have where they're most required. I won't go through the slide in detail, but most countries have been trying some or all of these interventions, looking at investing in the current workforce to get more hours, different shifts in working patterns, for example, bringing nursing and medical students into the workforce, which has major implications for the delivery of education. Trying to increase the number of active health workers through those who are in retirement or in active being brought into the workforce. Some countries looking at fast tracking the use of internationally trained health workers, and this is a big factor for some of the countries within the region. And as I said earlier, looking at volunteers and rapid deployment of community health workers as a way of rapid scaling up, particularly at local level. So when you take the first slide, which is the big challenges which are there irrespective of COVID, and then you put above that this hugely demanding overlay of COVID itself, I think there are several key points that need to be given consideration. And these points were ones that were very much identified during the series of seminars last year, which were supported by ADB and delivered by AAAH. So we need to be looking at improved readiness and responsiveness of health systems and the healthcare workers within those systems. And part of that is looking at the regulatory and legislative enablers that can make responsiveness easier, rather than has been the case in some countries, has slowed down responsiveness. So there's a challenge there for regulators, for those involved in accreditation as well, to ensure that we do not unnecessarily slow down the rapidity of response when we meet big challenges. Second common issue is the need to improve the data we have in order to then get to analysis and, most importantly, to action. I mean, one big example has been, how has the pandemic impacted on the absence rates of health and care workers? It's a critical day-by-day issue for health systems to be able to understand and therefore respond, but where the workforce gaps are most challenging. A third issue that very clearly has come through is the need for rapid and accurate communications, and that's from the system to the workforce within the system. That's harnessing the use of media to ensure that the right messages, accurate messages, are getting across, and ensuring that the population understands the challenges involved. Third point is the use of technology, and this is very much one of the key issues that we're discussing during the conference. And it's very clear that COVID has been an accelerator in the use of technology, which is already there, and it's now more widespread, and we're seeing new adaptations of technology in order to better support the delivery of services, and also within the education sphere itself in terms of improving education delivery. Something else that we need to give full consideration to is the fact that many workers and many systems have been working extremely hard, high levels of workload, high risk of burnout, and therefore a risk that we could have very poor retention of the current workforce over the next 2 or 3 years. We need to be looking at how to provide respite time whilst remaining flexible and agile in terms of how we can allocate the workers that are in the system. Something that came through on that basis very clearly in the seminars last year was the use of targeted incentives to enable workers to stay at work a bit longer perhaps, or to be reallocated to different regions or different parts of the system that were most challenging. That, I think, is necessary short-term interventions, but cannot be a long-term solution. So I think the critical point is my last one here, which is that we need to be looking at workforce sustainability, and that is partly about further investment in today's workforce. That's reskilling, upskilling, enabling them through technology to work in different teams, for example. But we also need to be thinking about the tomorrows, and that is about looking at how we ensure that the education is fit for purpose in terms of delivering workers who can work within a UHC environment. And the connection there is how we look at planning to give signals for what types of skills and what types of worker we need in the future. So my final slide, just in conclusion, I think it's important that all countries have developed an effective workforce plan. This is in the global strategy from WHO, but I think it's important that it's not a fixed in time plan. It's not a tick box exercise. It's a strategy that allows the organization, the country, to adapt as different challenges come. The plan can be adapted. It's not fixed in time. COVID has really educated us all in terms of being able to be rapid in adaptation and flexible in response. The second point, there's no magic solution here. We need to be looking at coordinated interventions across education and workforce and ensuring that the two do not work separate from each other. Thirdly, much of what I've described can be presented as a workforce problem, but the solutions are not just within the workforce. We need to be looking at service redesign, relocation, much more use of telehealth, for example. And a final point, just really something I've learned very, very clearly in the last year, 18 months, is that we cannot wait to be perfect in some of the responses. We need to look to be rapid, adaptable, and at all times try and take care that the ultimate goal is improved population health. And that even with the COVID challenges, we need to be working with COVID, but thinking beyond it in terms of what the workforce should look like. Thanks very much.
Wonderful. Thank you, Jim, for that excellent framing of the issues, not only in general, but also how they are being affected by COVID, and how many of them have the chance for acceleration also with the kind of innovation that's happened over the last year and some months. I think some of the interesting questions to bring forward to you later in the discussion will be about what will last out of those strategies that have been implemented during COVID-19, what can really be taken forward and to be seen as Sorry, did you hear anything of that? Or I was just thanking Jim very much for the framing, which I thought was excellent on both the workforce issues, but also the impact of COVID-19 and the acceleration that has given to the sector. And was thinking that a few of the issues to really bring forward in the question and answers afterwards are what are the kinds of strategies that will be taken forward after COVID, the kinds of accelerations or innovations in training, quick training and quick movement of people through the workforce, quick reskilling, and also the important role of coordination that he raised at the end, and where he sees good opportunities or good examples of coordination across ministries of health and ministries of education. So with that very good and overview given to us by Jim, let me now switch to Professor Nonglak. Professor Nonglak Pagaiya is an academic from Khon Kaen University in Thailand. She's focused on human resources for health management, policy, and planning. She has accumulated over 20 years experience in working for and advising ministries of health in Thailand, Myanmar, Cambodia, and the Maldives in human resource planning for health, with a strong focus on skill development for primary care and on long-term care. So Nonglak is going to outline how Thailand is upskilling its healthcare workforce and the challenges it is facing in doing so. Over to you, Nonglak.
Thank you, Wendy. Good afternoon, everyone from Thailand. What I'm going to discuss today, just only 2 points. First is that how Thailand have dealt with the challenge of the health workforce. And second, I'm going to share with you about the experience that we deal with the health workforce during the COVID-19 pandemic. First, about the health workforce challenge, it's just similar to what Professor Buchan have highlighted. So Thailand faces a problem of shortages of particularly doctor, nurse, inequity distribution, particularly during between urban and rural, where 60% of Thailand reside in rural, just only 16% of the doctor work there. And it's the high turnover rate of health workforce from rural make the problem getting worse. So that was 20 years ago. So I'm going to explain about how we use particularly that the educational strategy to solve the problem. On 20 years ago, when we start to implement the universal health coverage, we found that we have a huge shortage of doctors and nurses and other cadres. So the first strategy that we use is that we increase the production of this type of workforce, almost double up to the maximum of the educational sectors that they can carry out. But we found that once they graduate, the majority of them want to stay in urban. So we face a problem of distribution to rural. So what we do is that we implement the policy compulsory public service. So those who graduate from, those who study in the public academic institute, they will partly fund. And then they are compelled to provide public service, particularly in rural area, for about 3 to 4 years. And the other thing that we use to address the distribution is that there are at about 7,000 rural health centers, there is no doctor. So what we do is that we upskill the nurse and community health workers to be able to provide curative care for the villagers. In addition, we train the villagers to be the village health volunteer. And these people, they work alongside with the health workforce to provide preventive care to the people in the villagers. This strategy can be able to address the distribution, but not really 100% complete, because we still have many health workforce turnover from rural. So what we do is that we implement the targeted educational strategy, which is called the rural-oriented training track. So those students who come into this track, we're going to recruit them from rural. rural background. And then we will train them close to their hometown at the regional institution. And after they graduate, they have to return the service to their hometown or their communities for some certain period of year. With this approach, we can be able to retain health workforce longer than before. However, to attract and retain them, not just only need the educational strategy, but it needs some other strategy as well. We increase the financial incentive, also improve the career advancement for those who stay in rural. So if you work in rural, you might get higher salary compared to those your friends who stay in urban. And the opportunity for career advancement does not different, even you work either you work in rural or in urban area. That is the strategy that we have done during the normal period. However, for the last 18 months, we face the problem of the COVID-19 surge. The need for care much more higher than the available health workforce that we have. As a fact that we can expand the number of beds, we can expand the number of equipments, but we cannot produce health workforce within 1 month or 2 months or 1 week. It cannot be able that. So what we are using is that we try to optimum use the available health workforce that we have and looking for other resources that we can recruit. For instance, we use the approach of teamwork or skill mix. So the task sharing among the health professionals are implemented. For instance, some dentists have to come to join the preventive healthcare team to come to investigate the case, investigate the contact case, and also assist with the home isolation or the local quarantine place, something like that. So the border of the professional practice is more flexible. So kind of people, health personnel are working together as a team. And the other thing is that we strengthen the capacity of the village health volunteer to work along with the mainstream healthcare workers. So to provide surveillance in the communities as well as provide the services for the local quarantine. And we also involve some other partners like the local authority, the army, the policeman, and also the factory to do the factory quarantine. And also the NGO pay the part and other civil society as well. So this can create more health workforce in the system. So it's just like everybody can be health workforce at that time. And also we seek to recruit the retired person. We call the inactive health workforce, those who resign job, those who change job, those who retire. So we recruit them back for temporary approach. And the other thing is that we use the digital technology. We use the mobile technology, the internet technology to communicate between the health workforce and the patient at home so that it reduces the need for healthcare workforce. So these are the strategies that we use. Thank you, Wendy.
Great, thank you, Nonglak. That was a very good overview of the system and also of the kinds of challenges and ways in which Thailand has been reacting during the COVID crisis. I think maybe one of the things for us to pick up during the discussion is also a little bit more understanding on the skills mix and how those different skill areas actually work together to cover all of the service needs. Let me now switch over to Dodo, my colleague Dodo, Eduardo Banzon. He is a principal health specialist here at ADB in the Southeast Asia department. Dodo champions UHC and has long provided technical support to countries in Asia and Pacific in their pursuit of this goal. Before joining ADB, he was president and CEO of the Philippines Health Insurance Corporation, also a WHO regional advisor for health financing, and a World Bank senior health specialist, and a faculty member at the University of Philippines College of Medicine and the Ateneo University and Graduate School of Business. Dodo's going to provide a few examples or trends on how our developing member countries from the region have been scaling up their healthcare workforce in both quality and quantity. So over to you, Dodo.
Thank you, Wendy. Okay. So before COVID, ADB has been working with our developing member countries to improve health human resource. In a sense, they are trying to build up a workforce, and among the series of support that our countries have reached out to us has been, of course, the traditional type of support. It would be investments in health education infrastructure. So in Vietnam, we were asked to help upgrade the medical universities, and we had ongoing discussions with Indonesia, in Kazakhstan, all looking at increased investments in health education infrastructure as something, of course, that will lead to stronger skilling of health workforce. We've also are supporting what we call licensing and accreditation systems. So beyond, of course, the hardware part, you could actually, in the infrastructure, this has been shown to be quite good systems in strengthening, in increasing the skills of particularly what we call the health professionals, the more formal health workers. But because ADB is committed to supporting UHC, and that includes, of course, supporting primary care, we have also started to support, in a sense, community health workers from India to Bangladesh, and we're starting to do that in the Philippines as well. In all of this, we were supporting the use of digital tools, not just in skilling up, but in a sense, the digital skills of health workers. But we have to acknowledge that although we were starting to build up the skill sets of community health workers, a lot of our engagement with countries, because that's the way countries also talk to us, was really hospital-centric and care-centric. And we do acknowledge, of course, that even with that focus, there was really a shift of the fact that we were talking with community health workers. Now, COVID came along, and I think ADB, as we know, has really supported a lot of our DMCs in trying to respond to COVID. But it has also, in our response to COVID, we have also seen that we need to, in a sense, the direction of where we're going, that we need to bring in community health workers, were the correct path, that we need to invest in primary care workers was the correct directions. We now know that, for example, in COVID, countries that have strong community health workers has been the one that been able to do better job in detecting, isolating, and doing contact tracing of COVID cases. We've now seen the importance of community health workers in trying to educate people, not just on how to prevent COVID, on how to make sure that they do behaviors that minimize the spread of COVID, but also, for example, to explain and clarify questions and issues with vaccination. Of course, we have also seen how COVID has affected care, how the importance of having appropriate interventions against NCDs and the elderly. We know COVID affects those with comorbidities and the elderly much more. And we now know that if we move forward, as we try to go and manage this pandemic, there's really a need for us to build more health workers. Again, something ADB has been working on supporting, and that we need to further build up the skill sets of healthcare workers who can best respond to the needs of the elderly and those with NCDs. And finally, we have seen how countries that have invested in universal healthcare, in primary care, better address COVID-19. So what are we going to expect? And we're trying to see it now. Well, one thing we have seen before, but probably have more importance now, is really healthcare workers really have to become good in digital skills. That means it's not just using digital tools to train and educate, It's using digital tools to for health information system, the tracking of gaps, and really how to use digital tools tools by themselves in the provision of care. So this is something that you could imagine that eventually every health worker, in whether you are a traditional health professional or you are a community health worker, should be digitally proficient. We see, of course, again, an emphasis on something that was said by our friend Jim, that we need to train as a team, and in a sense, that's the message of primary care. To bring up to strengthen your primary care skills, you need to be trained as a team. You need to understand the value of the different type of health workers you're working to and the need to engage the communities. We have also seen the need for communication skills. Health workers could no longer just say, well, I'm a health worker, follow what I want. We've seen now with the challenge of trying to get people to follow the right behavior with regards to reducing the transmission, getting them to wear masks, to isolate, to accept vaccines. This requires good communication skills, which is something that is not naturally part of the training of health workers, and that should be there now. We've seen the need of disease surveillance skills, training in epidemiology and all that among all healthcare workers. And of course, we should continue to strengthen the training of community health workers. Over to you, Wendy.
Thank you, Dodo, for really outlining what some of the critical priority skill areas are going forward, and the different ways in which ADB has been working with countries to try to address some of these and the impacts of COVID. It also begs the question of whether or not the actual training systems need to change as well, whether we're going to see big changes in what medical schools, nursing schools, and others look like actually going forward. And how they put together those programs, and the way in which curriculum is put together. So now that we've had this very quick race through the range of issues, let me kick off by asking a couple of questions to each of our speakers. But I'd also really like to encourage everybody to put your questions into the chat box. We have some people who are also monitoring that, so that we can open this up a little bit further and really get all of the things that you're interested in out on the table. But first of all, over to Jim. In your remarks earlier, you outlined the vast global shortage of healthcare workers, and you also drew out some of the key learnings on how countries have been adapting since the pandemic started. But could you share some observations on trends and how education systems and education providers are adapting, and what it is that you see looking down the pike 10, 15, 20 years, or even just 5, if you see really any major changes happening as well in the way that training programs are actually put together and delivered. Thank you.
That's a great opening question. Thanks, Wendy. I think it's important that we maintain both a relatively short-term view of this, but also a longer-term view in thinking through the responses. I think one of the key issues that very much is coming through is greater emphasis on the use of technology. And that's for good reason, because in a sense, COVID has brought it to the fore very quickly in a way that was not the case beforehand. Different institutions, systems saying, we can't do this, we can't use this technology. Suddenly that is happening because of the urgent and immediate need. I think that technology is a great enabler, but in a sense, that's also my cautionary note. It should be a means to an end. And when we're looking at the education of healthcare workers, and we're looking at the delivery of healthcare, technology can, I think, improve efficiencies. It can accelerate the delivery of care. It can allow us to make better use of the skills of the workforce that we do have, and also provide modalities for improving and increasing the rapidity of training. But all of that has to be taken into consideration against the backdrop of what's it there for, and it's there to improve care. All of this is about improving UHC As we've already heard from Dodo, it's very much about focusing, I think, primarily on primary care and building that up as the foundation for any system that aspires to deliver UHC. So technology as a means to an end. A critical issue there is we don't focus too much on the hardware. We need to be looking at essentially the software. And I mean that in the broadest sense. It's who's going to be using the technology? Are they trained to use it effectively? Do they understand what the technology can provide to them in terms of improved efficiencies? And when we move the focus of technology into the education sector, I think there are 2 or 3 areas where if it's harnessed well, it can be hugely effective. There's an if in my response there, but I think we can be looking at technology that can better improve the connections between the worker and the patient, across the team of workers, between the team and the broader system. And the issue there is ensuring we have a platform that allows effective connection and communication, where everyone understands how to use it, and the outputs that are being used are understandable. They're not overcomplicated, not over technical. There's always a risk, I think, if we allow technology providers to drive the process, because they have their own priorities and they may not be the same priorities as is the case for health providers and governments. So there's a risk there that also has to be managed. I think the second point I'd emphasize in regards to technology and education is the ability to improve the delivery of education that is going to allow the worker to fit with the overall aims and objectives of the health system. Many education curricula, I think, need to be looked at and reviewed. I think COVID has exposed any limitations that exist, and greater use of technology can be part of the improvement process and the alignment process, so the education curricula better meet population health goals. I think within that, greater use of simulation is probably one way that we can scale up more rapidly, more quickly. And the third point I'd make in regards to technology is improved quality, standardized and improved quality of care. If we can use the technology to ensure that different workers are coming together as part of the training process. The reason I mentioned at the beginning short term as well as long term, I think if we only look at the long term, the risk is that we will only look at the types of health professional that take a long term to train. Doctors 10, 15 years before they're going to be specialists in the workforce in some countries. Critical to take that as part of the overall picture, but it mustn't drive it. I think we need to be in the short term looking at where we can invest in the current workforce to make them more effective. And secondly, look at cadres and occupations such as community health workers, which in many systems I think can provide a greater input into quality care. And part of that is, as Nonglak has already said, is about integration of community health workers as part of a broader team. So I'll call a halt to my contribution there, but very pleased to see already some questions coming in as well. Thank you.
Okay, excellent. Thank you, Jim. Now over to Nonglak. Thank you for describing the way that Thailand has understood the challenge, especially with increased pressure from COVID, and also for sharing how the education system is improving training for various healthcare occupations. In addition to your work within Thailand, you've also recently undertaken some regional research for ADB regarding workforce challenges in elderly care or long-term care. And I'd like to ask, what were the key recommendations stemming from that research, and what connections also to some of the broader strategies that you were talking about in the healthcare workforce system do you see going forward? Thank you.
Thank you, Wendy. The situation of increasing elderly It's happened globally in both developed and developing countries. And what we see is that in terms of workforce challenge, it repeats the same problem. First is that the shortage of a number of care workers. I would say the care workers who look after the elderly care. For instance, it is estimated that in 2030, the Asian Pacific is going to shortage about 19 billion care workers. So we need 19 million care workers to fill the gaps until 2030 so that we can be able to provide quality service to our elderly. And the second problem is about the distribution. It repeats the same problem. The majority want to stay in the urban and not many people want to stay in rural. And the other problem is the skills. Skills, many workforce does not have appropriate skill. Skill, I mean, it's not just only the hard skill to take care of the health of the elderly, but it's also the skill to work together as a team among the care worker who provide care to the elderly. And the fourth is about the turnover. So it's repeat the same. So the recommendation is that the first, it is the, since many Professor Buchan also said that we cannot produce doctor, nurse within a few years. You need like 4 to 6 years to produce a workforce. So you have, the country need to have a plan for a workforce to be able to carry out, to deliver care to elderly. So it needs a plan. And the plan for health workforce need to be costed. So need to be budget, including the budget for the remuneration of the workforce to retain them. This is the first thing. The second is that it is an opportunity for the educational sector to increase the production, to prepare this, because we cannot prepare the workers within a few months, a few years. So we need to start to produce, to prepare, to develop the workers for in relation to the needs of the country system. So I mean both the number and the quality. For instance, the education need to look at the quality of the skills that the care workers need to be able to provide services to the elderly. And third, the retention strategy is important because we found that many people, they cannot work longer to provide services to the elderly. So the high turnover rate should be addressed. So the government should also develop the incentive, which can be the financial or non-financial incentive to be able to retain them. And the movement need to support by the evidence-based information. So the country should also provide the evidence-based information to advocate the policy and practice. Thank you, Wendy.
Thank you, Nonglak. Dodo, turning to you, you've shared some promising examples from around the region and even including some from the ADB Health and Education portfolios. But looking ahead, what do you think are some of the key priorities and opportunities to support governments to upskill their healthcare workforce? And you know, how is it that you see this very big challenge of getting ministries or helping ministries of health and ministries of education to really collaborate well and to coordinate well in this area?
Wendy, I think one part of the pandemic is, how do we call this? It's the ongoing pandemic have highlighted the need for us to be much more creative, and I think that Jim and Nochan discussed that in order for us to build up our health workforce. And so I think the pandemic basically is like what a disaster that we should maximize, in a sense, doing the studies, because part of the reason that there has not been public collaboration is that in quite a number of countries don't actually have those numbers that tells us what would be the demand, what would be the future demand. Thailand is much ahead of a lot of other DMCs. We don't usually have that. And so I think getting ADB to support studies now, right, to see what would be the expected demand on health workforce with aging, with potential future health outbreaks, with NCDs, non-communicable disease coming in. So I think that's the first thing. Second, we've also seen, one of the things that we have actually seen, sorry, I did not discuss it, was part of the problem we had for a while was that the health professionals, the doctor, the nurses.
During this pandemic, because most of the things we can do that digitally.
Yes, sir. Okay. So our health professionals basically were insisting that there be lots more level of quality for them, right? And basically what you were not seeing. So if you look at it historically, probably in South Asia, even in the Philippines, we used to have this like health workers, for example, in the Philippines, midwives, 2 years of training. Then there was a push that it should be 4 years, right? So that they'll be more professional. Okay. In Sri Lanka, you used to have these health workers that was working in the uplands tea plantations, right? That basically were treated as doctors. Then basically the medical profession said, no, they should be, we are honest to goodness, they take the doctor training in order for them to be called doctors. So we've seen now that with the pandemic, we can't wait another 9 years, another 4 years to train, to build up this health workers, to transform some of our community health workers and be accepted as health professionals. So that's a challenge. Can we get countries to bring back what, in a sense, for me was great practices before, right? Something between the health professionals that we train, the community health workers, something in the middle, tech voc. And this is where, in a sense, health tech voc is something we're missing. So if we could strengthen health tech voc, where you have 6 months, 1 year program, then you could rapidly build up those health workers. Is it something, in a sense, what someone say, is it something that developing countries do because they don't have? Well, in the US they call it the licensed practice nursing, right? So in Europe you have this. You have basically these programs where basically the system recognizes them, even pays them, right? And because they're quick to produce, they're quick to produce. At the same time, they respond to very specific needs, primary care, I think elderly care, and all of that. I think it's time for Asia to start having that, like a health tech voc movement. And if this happens, then we can come in and support that. And finally, for me, the last is really addressing this debate on community health workers, because this debate is still ongoing. Shall they be part of the system, paid with salaries and all that, or shall they still be volunteers? And frankly, as we go from one country to the other in Asia, this is an ongoing, and it's an unresolved debate, And I think until we resolve it, it will be difficult to expand community health workers. Frankly, you can't expect enough volunteers forever, right? But then, of course, those who push for community work would say, no, you lose the essence of being community health workers if we start making it into a formal profession. So for me, that needs to be, I don't have an answer for that. I have my position, but then, that's something. And so these are the things. Finally, in the last, and I just like to emphasize one point, digital tools is something that has become, this COVID have shown us how important it is. So I think, that should be a default skill set now of every health worker. There should be no health worker who don't understand how to use the internet, how to use any digital device, because I think that's the quickest way in which we could upgrade them. We could monitor the care that they have, provide additional information, do health communications, all that. So I think that should be a basic skill of all health workers. Over to you, Wendy.
Thank you, Dodo. I see that there's been a couple of questions that are a little bit related to each other and that Jim has tried to answer, but maybe you can also just speak to very quickly. One is on the source of possible healthcare workers as informal care workers in the rural areas, also like the volunteer workers in Thailand. What kinds of short-term and medium-term interventions can happen? How can we formalize the skills and competencies of these informal workers? And also the previous question, which was asking about the ways in which bringing back people into the system, like retired staff, student staff, et cetera, what types of short, immediate update courses are needed before deployment? And are there any good examples that we can see in the region from either one of those sides, either the kind of training that's done for rural workers or these volunteer programs, or also bringing back retired staff and bringing in student staff? Can I give that to either Jim or Nonglak, if you have any good examples out there where you see this happening in interesting ways?
Yeah, I would share about the Karina question asking about if we recruit the retired or inactive health workforce, do we need the training? I think we need more is that the management skill, because we most of the people we recruit, they have some knowledge on the skill that they have to do, but we have to kind of look at the type of work that they can help with. For instance, in Thailand, we do the vaccination alongside with the curative. So we assume that for the vaccination, there are more work that the re-enter, the inactive person can do. So they will kind of help with the vaccination, and also they have to work alongside with the kind of mainstream health workforce for those who are recruited, until we kind of quite sure that they can work independently. So we use the working and learning and doing as one way of training, and also we kind of use the management system to assist with the work of the inactive person when we recruit back.
Thank you. And Jim, anything to add to that?
Yeah, yeah. I think the big question is the one that Dodo has already highlighted, which is if we don't try and effectively integrate community health workers in the broader health system, then we risk all sorts of inefficiencies. So we need to be looking to ensure that they are well integrated. And part of the answer there, as Nonglak has said, is to try and ensure that there's access to the same digital support and information in order to allow community health workers to be effectively supervised. The second element of Dodo's challenge, however, was that if you do integrate them, what does that mean in terms of their own status? Should they be paid? What should their access to training be? And I think the first driver is better integration. That should be the case in any country. The questions relating to how should community health workers be treated when they are integrated, I think is a system by system response. I don't think there is a universal answer there, but it would be understandable to look at, if you are bringing CHWs in broader into the workforce, what else needs to be in place to ensure that they continue to be part of a team and an effective team, whilst not losing their close engagement with the communities that they live in and help care for. So I think there's not a one size fits all answer to the second part, but the driver must be better integration. Thanks.
Thank you. And just to finish with two quick questions, I'm going to ask again if anybody has any interesting examples that they've seen, or ways in which they've seen the education sector and the health sector work together to radically transform curriculum development, training programs, deployment. If you have any good examples of that. And there's a second question here to Professor Buchan, that you mentioned that one of the responses in the pandemic was to start to bring nursing and medical students into the workforce earlier, and the implications this has for their education and the education providers. Could you elaborate, and could you also, and do you also think that this will have longer term implications or just a short term response?
Wendy, if you allow me, so we're doing a policy law now for the Philippines and universal health coverage. And one of the policy actions that will be for the next tranche for the next sub-program is that primary care will be integrated in all health professionals degree in the Philippines. Okay, so it attacks curriculum. Okay, it also requires that all licensure exams should have a primary care. So again, that's so it and so the lead agency here is CHED, sorry, the Commission on Higher Education in the Philippines, not just the Department of Health. So this is something in the future, something we could see. You know, if this works, this could be an approach that can be done on how to get education and health people work together. And here, in a sense, try to shift the degree programs on health in the Philippines from a hospital-centric approach to a much more primary care UHC approach. We still don't know whether this will work, but I think that's one example that well, I'm directly aware of because we will be engaged in this.
Okay, thank you, Dodo. Anybody else want to respond? Jim or Nonglak?
Yeah, I'd be happy to respond to the specific question about student nurses and doctors. This was very much, part of the emergency response in many countries, and I think it was understandable, and it often required regulatory change or enablers to be put in place to allow it to happen. But it brings with it huge risks. Partly the risks are for the individual nursing and medical students themselves in terms of whether they have had any harm, physical or psychological. The equally important issue beyond looking at that is to ensure that they are enabled to complete their education. I think in many countries that has meant delays in terms of them being able to fully qualify. So we need to be sure that that can be put in place. But I think longer term, what we need to be thinking about, and Dodo's alluded to it also, is looking at integration across the different professions, IPE, so that people are coming out of university already ready and willing and able to work as part of a team rather than having too many parallel systems. I think COVID has accelerated that, the understanding of the need for that. So I think the ball is in the court of the education sector to ensure that they can deliver on that in terms of the future workforce. We talk about future-proofing. What COVID has told us is that you might have thought at the beginning of 2020 you were future-proofed. 3 months later, you weren't. Things can change very rapidly.
Thank you. And Nonglak, any last words?
Yeah, just really quick. We have an example of the collaboration between the educational sector and the medical school. I mean that since the medical school, they have their limited capacity as well, but the Ministry of Public Health want more doctors. So what they do is that they work together and kind of for the first 3 years, the medical student will study in the medical school. For the last 3 years, they will study and train in the Ministry of Public Health facilities. So that is a collaboration that kind of have a good output of the doctor. So the doctor, they are familiar with the health system before they graduate.
Great, thank you. Well, this has been an engaging hour and it's gone by really fast. I'll just wrap up with a few comments here at the end. Things that are highlights from the session. First is the need for planning to produce the health workforce that is fit for purpose, and the extent to which the pandemic plans have taught us about how the complications of surging the workforce and highlighting some of the larger underlying gaps in workforce planning to date. We've seen that through countries globally all over the world. The second is in terms of the examples that Nonglak gave from Thailand about taking the multi-pronged approach over a period of time to address the poor distribution of healthcare workers in the short and long term, and in particular in upskilling volunteers and non-health actors to create a necessary skill mix, and one that is also being further elaborated as they expand their long-term care system as well. And the third is the centrality of the healthcare workers, and they're close to people for quality and primary care and health promotion. And looking forward, I think all three of the speakers said that this is going to be a critical path going forward, much stronger focus on primary and community healthcare workers, and the need to skill them up for that health promotion. The fourth area is in terms of digital health tools, which hold great promise, but also must be aimed at improving health outcomes, and success relies on being digitally literate healthcare workers and finding effective ways to build that into curriculum and training programs and reskilling and upskilling programs as well. And finally, Jim's admonition to not let perfect be the enemy of good. We can't just have long-term plan, but also need to start now and apply what we've learned from the pandemic. And we need to be creative and learn as we do. And there's just an enormous amount of learning and adaptation and innovation that's happened in the last year and a half. So going forward, this is really going to be important to harvest and to move on to the next steps. I'd like to thank all three of our panelists, Jim, Nonglak, and Dodo, for their excellent presentations today and the discussion, and also the organizers of the session, Meredith, Ben, and Mikyung from ADB, for putting together such a great panel session. Thank you very much, and please everybody enjoy the rest of the skills forum. Thank you. Bye-bye.